professional training has to be outcomes oriented. It becomes really complex when these kind of trainings are embedded in real world situations. Any programmer, any such training initiative should very logically ask whether the intended outcomes are achieved or not, whether the program was effective or not. Evaluating these kind of initiatives, especially for medical doctors, when scaled out in a country as vast as India, gets a bit complex. The Indian Academy of Pediatrics launched a national initiative to train pediatricians in nurturing care for early childhood development. The program was called the IAP Nurture Program. 200 workshops were conducted between 2022 and 2024, wherein 7,047 pediatricians were trained across the country. The question, did the training change their knowledge, skills, and practice? And more importantly, how can it be further improved? Traditionally, for assessing the effect of training programs, evaluators would usually go for a pre-training assessment and a post-training assessment, and they would compare the scores. Now, a lot of information goes under the carpet while just providing the p-values of pre and post-training comparisons. These are good assessments, especially when we're just trying to assess knowledge scores, change in knowledge scores after training, and more so if the results are if the responses are clearly dichotomous, correct, wrong. Now, anything in between, especially when it concerns behavioral aspects like nurturing care training, it becomes a bit complex. Further, these kind of pre-post assessments would not be able to comment whether the change was because the participants were very worthy of receiving the trainings, they were very active, they could actively receive the training, or whether the medium was very effective in which the training was conducted, or whether the trainers were very effective, or whether it was the content. So too many things get complicated here, and pointing out what really worked becomes ambiguous. Now, the pre and post tests also miss out if there were any softer changes in actual clinical practice. It does not really comment on whether the programs succeeded or on what aspects did the program really struggle, what are the implementation barriers, and more so across the different contexts, and what exactly to improve when we're considering to scale. What we did for this evaluation is a triphasic mixed methods design. That means there are quantitative numbers and there are qualitative narratives, and assuming that neither of this quant or qual would be sufficient in itself, there has to be a triangulation that must happen between the two elements. And the triangulation would definitely lead to convergence on certain aspects. Okay, the quant and the qual tell the same story here. There could be divergence where we would get something very important to reflect upon. And these kind of cross comparisons and triangulations definitely lead to a lot of learnings coming in the process. What we did in this triphasic design is we used an approach where each succeeding phase built on the previous phase. The first phase was to understand the context. So we went around conducting key informant interviews with the program designers themselves. So what was their vision? What kind of iterative processes were involved? Who all were involved? What particular aspects were taken care of? What sensitivities existed? So we tried to understand the organizer's perspective and the context in which the program was embedded. 9 key informant interviews were conducted, and the intention was to identify or curate the more important or priority items of inquiry going forward for the future phases. Now, in phase 2, this was the soul of the evaluation, where we evaluated the training. We had access to the pre-tests. 4,155 pre-tests were available. We had access to the post-test. 2,596 such post-tests were available. We used advanced statistical modeling to compare the pre and post-test results. We also had access to the feedback forms. 1506 feedback forms are analyzed. These had both quantitative and qualitative inputs. And 205, so an online survey was conducted in which 205 responses were analyzed, and further 18 in-depth interviews were also done. So here you can see in this training evaluation, it was a concurrent quant plus qual approach. Now, after this phase 2 was done, we went to phase 3, where we looked at the trainer perspective. We organized focus group discussions with trainers across the country, and we tried to understand their perspectives about how effective the program was, what were the challenges and solutions that they perceived could work out, and what are the further improvements that could be suggested. Now, these trainers, after they conducted the workshops, were also available for the trainees to contact them as and when needed. So, some of the trainers had very rich information about how the trainees were going with their practice, going on with their practice after receiving the workshop. So, some longitudinal support mechanism existed. These were non-formal mechanisms which could be enumerated during these group discussions. Now, this is one important step which most evaluators mess up with. We collect quantitative data, we collect qualitative data. Now, these two segments exist in silos. How do we integrate the two? So, that's the crux of this entire evaluation. So, the integration was for convergence, to understand where the divergence would be there, how we could expand on our enquiries, and how could we explain things. So, many times there are interventions and there will be intended and unintended outcomes. Further, there is a risk that even if there is an intended outcome, how do we prove that it is because of this particular intervention? So that kind of attribution becomes very challenging. So when we are using mixed methods approaches, especially with very strong integration component, things become a bit more clearer. Now in this particular project, let's try to appreciate this fact. The quantitative data showed high satisfaction scores for the workshops, but the qualitative data gave us very important understanding about why those workshops really worked. One of the most important findings was that the participants very strongly identified that the hands-on workstations where the trainers demonstrated the skills were the most important aspect of the workshop, which really led to higher understanding and which led to the learning to stick to them even after the workshops are done. Integrating these findings, we found that satisfaction was high because the design included practice elements and not just content delivery. We used certain frameworks for this assessment. The major guiding framework was the REAIM framework. R for reach, E for effectiveness, A for adoption, I for implementation, and M for maintenance. To explore further the E component, the effectiveness component, we branched out using the Moore's framework, where we went up to level, we could not do the patient outcomes and the community outcomes, but all other levels were done. For the maintenance, here we must flag this, that while talking about the REAIM framework, the maintenance could indicate whether the effect of the training were sustained among the individual participants and whether the effect of the training was sustained inside the system after the training has been done, after the project lifetime. So the maintenance components were also explored. While looking at the findings of our evaluation, we could conclude that the training had been successful in accomplishing its milestone of 200 workshops within the stipulated time. It had managed to reach 7,047 pediatricians. Of course, it must have been very uphill, a challenge for them, trying to mobilize private practitioners, medical faculty, public health, facility-based providers to attend these workshops. So that's a success. And there were many positive findings, like the trainee satisfaction was very high, and we tried to look at the granularity of this particular aspect. And we found that across individual workshops, the satisfaction levels were consistently high. And pediatricians also said that the training had led to improved developmental monitoring in routine well-child visits. They felt equipped to counsel parents on early childhood development, learning and certain aspects. Though we could not interact with the patients directly, but using the pediatricians' viewpoints as surrogate markers for the patients, we found that families had reported positively, had given positive feedback about the impact or the effect of the training on the pediatrician's practice. We also identified certain challenges. So logistical constraints were identified across regions, trying to mobilize trainers, trying to mobilize trainees, trying to organize centers. So those aspects, finalizing on the dates of training, those were certain aspects that were identified. Trainer confidence also was reported to be heterogeneous. And people felt that had there been a follow-up or a longitudinal support mechanism and a reinforcement training, that would have been even more helpful. Now, here I would like to highlight this to you. Mixed methods surfaced what numbers alone could not. Sample this particular quotable quote. One of the trainees reported that previously we did not counsel on such issues, but now we have made it a priority to engage with parents more effectively. Now you see the intention or the attitudinal shift, the behavioral shift that has happened, which may not be still reflecting in quantitative numbers. So here the participant has mentioned that we have made it a priority to engage. Now that's an intention, that's a change in the shift in the intention of the pediatrician, which quantitative scores might or might not be able to unravel, but qualitative has done very well. So triangulating these would be very useful. This evaluation got recently published in the BMJ Paediatrics Open. It's Sharmila Mukherjee et al., March 2026. The DOI number has been mentioned here. We'll also try to provide a link to the paper for those who are interested to go through the full paper. We tried to, now reflecting on why this study really matters beyond this publication. In this evaluation, we've tried to build in some amount of empathy. So we tried to look at the approaches from three stakeholders' perspectives. For funders, from the funders' perspective, we tried to ask, did the program work? And we found some evidence, yes, very scientifically organized evidence. From the government perspective, we tried to ask, should we scale it? So we could provide some quantitative and qualitative evidence that could be deliberated upon while planning a scale-up. And from the implementer side, we tried to ask, what should we fix going forward? And we did find some barriers and some aspects that could be further strengthened going forward. Irrespective of what kind of evaluation is done, it is important to ask this question. Does the method match the question? This is furthermore important if you are the one consigning this evaluation, or you are a funder, or you are the end user of this evaluation. This is the key question. Evaluation done well is not just a compliance exercise. It is how we learn. It is how programs get better. It is how investments in people translate into real outcomes. And the questions and the methods become critical, especially when the issues to be addressed are very sensitive. In this case, it was about childhood, nurturing care, and development. Thank you for being with us.